Please note, the opinions expressed in this podcast are those of the individual speakers and do not necessarily reflect the views of Tri-County Orthopedics. Any medical advice or treatment recommendations discussed should always be reviewed with your own healthcare provider. This podcast is not a substitute for professional medical advice, diagnosis, or treatment. All right, welcome back to the podcast here on this episode of the OrthoZone. We're very fortunate to have back Dr. Claudia Ginsberg, one of our esteemed colleagues who's one of our sports medicine specialists at Tri-County Orthopedics. I'm going to interview her today. I'm Steve Hunt, one of the orthopedic surgeons who's also a sports medicine specialist. So, Claudia, it's great to have you back on the podcast.
Thanks so much, Steve. Happy to be here.
So we have an interesting topic that, somewhat tricky, I think, for all of us to treat at times and somewhat scary for patients who are going through it. And this is known in our jargon as adhesive capsulitis, but more commonly known as frozen shoulder. So briefly, what is a frozen shoulder or adhesive capsulitis?
So adhesive capsulitis is a condition of the shoulder that's characterized by pain and limited range of motion and often can really affect patients' ability to function with the upper extremity.
So who gets it? Is there a certain demographic that tends to be typical for this?
Yeah, the typical patient is going to be a woman between the ages of 40 and 60 who has had sometimes a month or a few months of discomfort in the shoulder where they just can't use it for all the things that they want to use it for. They usually don't have a ton of pain if the arm is just resting by their side, but if they go to put their hair up in a ponytail, if they go to press the snooze button on the alarm, if they try to put deodorant under the opposite armpit, they can sometimes get severe pain, especially if they do it quickly. And so patients will then learn not to use the arm for all the things that they would normally use it for. And it's not only women, I definitely see it in men, but patients that have endocrine disorders, any diabetics are certainly at increased risk for having frozen shoulder. Patients who recently had surgery, even recent vaccinations. There's some weird overlap between orthopedics and endocrine and neurology. It sort of all comes together in a soup that results in a inflamed, tight, painful shoulder, and it's really painful for patients.
That is for sure. If you've experienced this problem or if you've seen patients with it, they are definitely suffering, and it's very unfortunate. What does the capsulitis mean exactly?
So itis means inflammation. So tendinitis, inflammation of a tendon. The capsule of the shoulder are the soft tissues. It's not muscle, it's not bone. It's sort of a combination of just tissues that hold together the bones, including the ligaments sort of around the shoulder joint. And it's almost like a bubble or a balloon that kind of keeps the shoulder together.
And you mentioned a couple things there before that could have happened and then maybe they experience pain, but are there any known triggers? Like I've had some patients who have had like a minor trauma and then it set things in motion. Is there anything that's known out there?
Right. So that's very common where people will say, 6 months ago, I just wrenched my arm on the stairs and I didn't actually lose my footing, but I kind of twisted my arm. And it was sometime around that time that I just started developing pain, and it just gradually got worse and worse to the point now where I just can't sleep on it at night and I can't use it for all the things I want to use it for anymore. So a small trauma, it'll often start with an inflammation. Maybe someone started a little weightlifting program because they were told that was good for them, and then all of a sudden the shoulder, they stopped the weightlifting, but the shoulder just got worse and worse, kept getting more painful and more restricted. So there's often been a little bit of tendinitis or an inflammation of sorts that then morphs into this very tight shoulder that just doesn't go in all the directions that the patient wants to use it in. Unhooking the bra is like a big one. So
I have that problem infrequently for myself, but I can certainly hear that.
It's the wallet. That's a good point.
Yes, that's true. It's a wallet for men, or the belt.
Taking out the wallet out of
the
the back pocket. They'll notice that pretty commonly.
But going back to sort of who does get it, I was looking up just some statistics on some of our literature suggests that, overall the incidence is about 2 to 5% of the general population. Right. But in diabetics in 40 to 60, it can be 20 to 40%. 100%. So,
Right.
so certainly those endocrine problems do factor in here.
And I would say menopause. There's so much that we're learning about menopause and so much we don't know about it. But there's definitely women between the ages of 40 and 60, it's almost like a rite of passage. They're going to get shoulder pain. And is it just going to be a tendinitis, or is it going to be frozen shoulder? Is it going to be a calcific tendinitis? The inflammation that happens, I think, in the perimenopausal period, there's a role for that. And that's vague to say, but that's all we know.
Yeah, and I think there's going to be a lot more research coming out. And I will say, as a hip specialist as well, there's definitely something perimenopausal about all the hip pathology we see. So,
yes, the big joints.
I think that's another topic we have to explore.
I think we'll be back.
Maybe we'll get Dr. Mary Hunt in here on that one.
Okay.
A little OB. So let's back up a little bit. So patient comes in and they have this complaint of shoulder pain, and you're evaluating them and you suspect adhesive capsulitis. What's the first thing that tips you off, and then how do you work it up?
So I think the history is definitely the first thing that's going to tip you off, because it's always going to be at least a month to 6 months or longer of pain. It's not something where they had great range of motion 2 days ago and then all of a sudden today they can't move their arm. There's always a longer period of time that this has been creeping up on them. And then the pain, the amount of pain. Sometimes patients are literally in tears describing to me how much pain they have when they try to take off a t-shirt, or especially if it's a tighter shirt or a jog bra. And so, the history alone, I often will suspect it a person in the right age range or has a characteristic history. And then examining the patient, you really relying on the fact that they're in a lot of pain. You have to be careful with how you examine them, because there's even an aftermath. So you try to stretch their arm up overhead, for example, and they'll either push you away or stop you sometimes, or once the arm is back down to their side, they start rubbing their arm, or you can see they're almost in tears. Sometimes you can just tell how much pain there is. And these patients usually, they're limited, especially when they're trying to bring their arm behind their back and out to the side, sort of up overhead, but out to the side, behind the back, what we call internal and external rotation.
Rotational deficits seem to be very key for this.
And their strength is usually fine.
Right, within their arc of motion that they have. And I think the key, from my standpoint looking at this, is passively, we may be able to move them around, and full motion, that's not necessarily adhesive capsulitis always. It's when the passive and active motion kind of match up of both being exceptionally tight, generally.
Right. So what that means is that someone themselves, they're trying to move the arm and they get stuck, and I can't even push it beyond where they get stuck. That's called limited active and passive range of motion. Sometimes patients will just have pain and they get to a certain point where they feel like they're stuck, but if I lay my hands on them and gently try to coax the shoulder, I can actually get it to move further than they can. That's not frozen shoulder. There's all different things that could be.
Right. Maybe a rotator cuff tear or some instability event or something
calcific
like
tendinitis, impingements, bursitis,
So what sort of workup do you do then? Do you get x-rays? Do you get a CAT scan, an MRI? Is there blood work involved?
Right. So the physical exam, the history, now you have a suspicion that there might be a frozen shoulder, but there are other things that can look a lot like frozen shoulders. So sometimes if someone has arthritis at an earlier age in the shoulder, that can kind of look like this, or even calcium deposits could be limiting someone's range of motion. Big bone spurs can do it. So after the history and the physical exam, you want to get an x-ray. You want to make sure that there's nothing on the x-ray that looks like it could be blocking someone's range of motion, or that would offer another explanation for why they're having pain and limited range of motion. And usually the x-ray is normal. And then the patient's looking at you like, there's nothing wrong with my shoulder?
Exactly.
And sometimes they're sure that there's something cracked or chipped or something torn because the amount of pain is just unreasonable. How could that be? At that point, I usually explain to patients what's going on and how it's happened. And some of them have heard of frozen shoulder before. I would say the vast majority have not. And so understanding it is key.
And so how do you counsel them? So what do you say, generally when we're talking with patients, we sort of try to educate about the natural history of a process, and then we try to educate about what are interventions that we think are going to work at this time or not.
Right.
So how do you counsel them?
So I'll usually say, well, great, the x-ray looks really good. I don't see anything on the x-ray that would be blocking your range of motion, but there's a lot more in a shoulder than just the bones. And in your case, from your presentation, I believe you have a condition that's called frozen shoulder. And this often starts as an inflammation, but over time, this shoulder has tightened up. All the soft tissues have just sort of tightened up like a drum, giving you some limited painful range of motion. And the treatment is, number one, we need to control your pain. We have to find some way so that you're not so miserable, so that then we can stretch it out into the very positions that you have not really wanted to get the shoulder to go into. And that's often done with diligent home stretching exercises that I go over with the patient in the office, but it's really much better if we can also get the help of a physical therapist to help bring the arm into various positions that the patient is reluctant to bring it into.
Right. And so there's traditionally been thought of as 3 phases of this process. Mm-hmm. And so there's a freezing phase, right, when it tends to be
painful and the shoulder is starting to tighten up, and then the frozen stage where they just have lost their range of motion and their pain is actually getting a little better for some reason in that stage, and then the thawing phase where the pain is improving, the range of motion is improving.
And so the natural history suggests that for many people this process will go away eventually.
Right. So if you look it up, you'll see, after 2 years it just goes away. But I don't know anyone who's willing to just live with this painful shoulder for 2 years using just prayer as like the only treatment. So yeah, usually we'll either talk about oral medications or a cortisone injection for pain control, home exercises, and physical therapy. I think the combination of something for pain and understanding what's going on, and then patients are then maybe more willing to stretch it into various positions. But if you don't convey to them that you understand what's going on and that, their whole life they've been told if it hurts, you shouldn't do that. But this is not one of those things. Like, you have to gently bring the arm into the various ranges of motion and positions that do provide some discomfort. You have to do that or you're not going to release some of the tissue that has become so tight.
So do you prescribe anti-inflammatories generally if the patient can tolerate them at the
Right.
visit?
So there's a lot of patients that are on medications where they either can't take an anti-inflammatory or they have really sensitive GI tract, or for whatever reason they've just been told because of blood pressure or cardiac issues, whatever, they've been told that they can't take anti-inflammatories. If they can't, there is certainly the option of a cortisone injection, which is really the equivalent of taking an anti-inflammatory and putting it directly into the shoulder. And it's very effective for people, and most people will say that they did get a lot of pain relief. They don't get back their range of motion just having an injection or taking these medicines, but if their pain is less, now they're a much better candidate to start the stretching exercises both at home and with the PT.
Right. I often counsel patients with cortisone. It sort of is a way to decrease maybe the irritability of the joint, and then maybe it's allowing the tissue to be a little more elastic. So getting to the PT, we might differ on this one. So how early do you suggest someone go start physical therapy versus doing just some home exercises, working on stretching on their own? In other words, for me, when someone's super acutely kind of getting into this freezing phase, I think like doing therapy and stretching them and creating all this other irritability is like trying to open a door running it head first.
It can backfire. So you kind of get a sense of where they are in the phases, and that's a gestalt thing about when they should really start physical therapy. But yes, there are many studies that show that if in phase 1, where you're in the process of freezing, where it really hasn't gotten to the full-blown frozen shoulder yet, that it just doesn't do much to really start PT at that time. But to me, the most important thing is that they understand what's going on.
Absolutely.
And that they know that you know what's going on, so that they'll trust in what you're telling them to do. Because like I said, the whole life they've been told, if it hurts, don't do that.
Do you think MRIs are particularly helpful for this problem?
It doesn't do a whole lot, at least initially, right? So there are definitely some patients that they want an MRI because they are concerned and they are sure that there's something else going on than what you've just told them. But most insurance won't pay for it right away anyway. Usually they want you to see some conservative treatment first. But it's not necessary to diagnose a frozen shoulder. It really is a clinical diagnosis. It's often what we call a diagnosis of exclusion, when you sort of ruled out some other things, but you believe it's a frozen shoulder. You can start treatment right away. An MRI can sometimes show certain things that would suggest a frozen shoulder. So MRI can sometimes show scarring in the capsule and various scar tissue and the interval being tight, but you definitely don't need an MRI to start treatment.
Yeah, I think you want to be careful rushing for an MRI. I tend to reserve it for patients who are failing to progress in any way. But Jim Andrews, one of our famous sports medicine orthopedists, used to say, if you want to see something wrong in the shoulder, get an MRI of the shoulder. So MRIs of the shoulder notoriously show
you're 50 or 60,
show a lot of pathology.
There's stuff in there.
So we mentioned cortisone injections. There's been some studies looking at other types of injections, whether it's saline injections, hydrodissection, or PRP. Any thoughts on that? Do you use that?
I don't think it's standard of care, but there are different types of treatments that have presented themselves as options as we have new technologies and we have various sort of new literature. Capsular distension, which is where there's a needle put into the capsule of the shoulder and then usually saline used to blow up the capsule and distend it and stretch it out.
Kind of like a water balloon.
Like a water balloon, right? I have on a rare occasion sent someone to have that done. The feedback I've gotten is that it's extremely painful and torturous. So I tend not to suggest that too much. But massage, acupuncture, dry needling, heat, these are definitely other adjuncts that people will use, and I think it can be variably helpful, but I think that the main treatments are going to be something for pain control and gentle stretching, not aggressive stretching, but gentle stretching into the very directions that the patient has not really wanted to move the arm.
Yeah, I agree. I do encourage people to explore those other alternatives as well because they're less invasive than surgeries, which brings us to when is the right time to have an operation for this?
Right. It's really a rare patient in my patient base and population that I ever send for surgery. The diabetics tend to have a more painful, longer, protracted course. And so when I have sent someone for either lysis of adhesions or manipulation under anesthesia, which are the surgical procedures that are usually offered, it's almost always a diabetic that has had a really hard go of it for a long period of time, and we kind of throw in the towel. But usually we can get those people better even without.
Yeah, I think in my experience from the surgical side of it, it's pretty rare to do someone who is not like a post-surgical person who just developed adhesions and scarring from a fracture or a rotator cuff surgery. And the two types of procedures we do, as you mentioned, we either manipulate the patient under anesthesia, so we give you a nerve block, you go to sleep, and we literally manually break up the scar tissue by manipulating it while you're asleep. Or we also, at the same time, do an arthroscopy. We use electrocautery to kind of release some of these thickened tissues, and then we manipulate you. Probably a little more targeted in that situation. But the post-op protocol, I can get full motion, and I show patients the video in the OR. It doesn't mean you're walking out 2 days later with full motion. You still got to work very hard at it. There's definitely recurrence in those situations.
You brought up another alternative treatment that I've never sent someone for, but I did have a patient who went for it on their own, a suprascapular nerve block.
Oh, yeah.
And so there would be either pain management physicians or physiatrists that will do a nerve block as a way of controlling pain so that a patient could then do a better job with the exercises and specifically the stretching. So again, not as common, but that is another option that you can read about. And yeah.
Yeah, and essentially they're injecting numbing medicine around the nerve. That gives you the sensation of your shoulder joint. So it makes sense. You block that. That's where a ton of the inflammation is and the pain generation is. Yeah. So, well, I'm glad we were able to have this talk, but I guess one of the questions I have is, because I heard you speak on this maybe 5 or 7 years ago, and I feel like you have a particular interest in this topic. And so what is it about adhesive capsulitis or frozen shoulder that you enjoy treating or for your patients?
I think I like it because these patients have often had so much pain for so long, and they've often seen other physicians that either didn't know what it was or maybe it wasn't full-blown frozen shoulder when they saw them. So they've just been suffering with pain for so long, and they're so happy to have a diagnosis. And you can take someone who comes in the first visit literally in tears and provide some reassurance, provide the right direction, and they come back to you 6 weeks later, often not perfect because this is a condition that takes 3 to 6 months or longer to eventually go away, but they're better, and they're so happy to have had someone who could kind of guide them in the right direction, and they make progress. And I'll often say to them from the first visit, this is a bad diagnosis because it is so painful, and it is going to take another 3 to 6 months to go away, and you are going to have to put in the effort going to physical therapy and doing your home exercises. But it's also a great diagnosis because you're going to get rid of it. It's going to go away, and we're going to be able to have a conversation in a few months where where you're going to tell me how great your shoulder's doing and all the things that you're able to do now that you couldn't do before. And it's not going to come back again in this shoulder. So it's kind of a discrete time, maybe a bad memory or a nightmare that you will have, but then it will be done. And you are at risk for having it occur in the opposite shoulder, but we're going to get through this together. And so I really like that sort of partnering with the patient, and they'll trust you if you really can show that you understand this and that there is an end in sight.
Yeah, it's interesting that some patients do have it in the other shoulder years later. I think the good thing is if they've been educated, they kind of understand the process, so they know what to do a little bit.
The second time around,
it's a little bit
not in the same shoulder, but
easier.
When they get it in the other shoulder, they really knew what it was. They started the exercises right away. They often come in much sooner than they came in for the first one. It's usually not as big an ordeal as it was the first time.
That's great. Well, I really enjoyed this conversation. Hopefully everyone listening to this podcast found something very interesting to take out of this. And thanks again, Dr. Ginsberg, for being here for this.
Thank you.
If you enjoyed today's episode, be sure to subscribe so you never miss an update. Don't forget to share the podcast with others who might find it helpful, and follow us on Facebook and Instagram at Tri-County Orthopedics to stay connected. Thanks again for tuning in, and we'll catch you next time.